Welcome to our CHD series. Today's topic is going to be on cognitive and social development in adolescence. My name is Dr. Marcia Asserman. I'm a pediatric neuropsychologist at the Alberta Children's Hospital. I'd like to make a couple of acknowledgements. The first is to acknowledge that the Alberta Children's Hospital, which is located in Calgary, Alberta, is in the heart of southern Alberta, which acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta, District 5 and 6. And on this land and in this place, we strive to learn together, walk together, and grow together in a good way. The second acknowledgement is I'd like to know that the purpose of these sessions is to provide some education, resources, and learning to families. Not all the information in these sessions will be applicable to every family, but the hope is that this provides some thoughts to consider around your child's growth and learning, and to open conversations with your cardiology team where you receive care. We recognize and normalize that some of the information presented may be difficult to hear or see, or may trigger some emotions for certain individuals. Please know that there are resources available. If you have questions, if you need some support, please reach out to your cardiac team. So today we're going to talk about adolescence. The definition of adolescence, when you kind of look it up, it talks about a transition from a state of dependence when they're young to relative independence as they get older. And this period is characterized by a lot of changes, both physical in terms of physical appearance, as well as changes in mood and changes in behavior. And it starts around puberty and ends when an individual attains a stable role in society. There's a couple of typical adolescent behavior changes. There's major changes in social relationships. Adolescents increase their distance from parents and start to spend much more time with their peers. So they spend about four times more time interacting with peers than adults. And there's an emerging sexual interest as well for many adolescents. And I like this little slide because while it's obviously a joke, it's pretty accurate. So the brain of a teenager is developing and going through some major changes. But if you think about kind of what are the things that are most important to them that they seem to be able to learn and remember, they don't seem to correspond to anything that seems to be important, right? So they're thinking about peers, they're thinking about girls and boys, they're thinking about their main interests. All of a sudden they're embarrassed by parents. They're able to remember, long song lyrics, but can't remember their homework. So there's a lot of truth to this particular slide. One of the biggest things that happens during adolescence is, and actually throughout development, is that our brains are very social brains. Adolescence is a time where that really starts to become very prominent. And the social brain is a complex network of a lot of brain areas that allow us to recognize others and evaluate their mental states, which might include beliefs, desires, or intentions, thinking about other people's thinking, as well as understanding and evaluating other people's feelings and actions. And in order to interact with others, we need to be able to recognize facial expressions and gestures, thoughts, feelings, and then predict other people's actions and communicate effectively. So all of those skills are part of that social brain network. And when we think about brain development and brain areas, the network involved in the social brain includes a variety of regions, but the main ones to really focus on are the medial prefrontal cortex. So that's the part of the brain that's involved in judgment, response inhibition, the amygdala, which is involved in emotion and emotional responses, and the superior temporal sulcus, which is involved in language. So some of the brain changes that happen in adolescence really occur in that prefrontal cortex, which is part of that social brain. The prefrontal cortex is in the very front of the brain behind the forehead, and it's involved in decision-making, inhibition, planning, social interactions, and self-awareness. There's a pretty dramatic development in the prefrontal cortex that takes place during adolescence. And we know that kids with congenital heart disease show changes in all aspects of prefrontal cortical development. They tend to have smaller prefrontal cortices, and that kind of corresponds to some of the difficulties with decision-making and inhibition that we often see in kids with CHD. And I'll talk more specifically about this a little bit later. One of the things that also happens to brains of kids and teens over time is that the white matter of the brain increases, particularly in young childhood and adolescence, and the gray matter tend to decrease over the teen years. So the slide here, you can see that gray matter kind of peaks at puberty and then starts to decline. And white matter continues to increase throughout adolescence and into young adulthood. And that decline in the prefrontal cortex volume and gray matter corresponds to what we call synaptic pruning. So the idea that if you don't use it, you lose it, is very much accurate about our brains. So we keep the connections that are used regularly over and over again, and then the brain gets rid of connections that are not being used. And one of the thoughts about adolescence is that this reflects kind of uneven brain development. Teens are quite capable of verbalizing the appropriate response. So their abstract reasoning, their memory, their formal capacity for planning are quite developed by about 15 or 16. So if you ask them a question about risk, reward, they're able to identify very similar answers as adults about what's risky, what they should do, what they shouldn't do. But their ability to implement those actions in the context of in the social context is far less developed. Thinking before acting or choosing between safer, riskier behaviors, even though they can verbalize what would be the best course of action. And their judgment seems to be easily overwhelmed by urges for new experiences, thrill-seeking, and some of the impulses that they experience. So this is kind of a slide that reflects that as well, that they are able to verbalize, they have the cognitive skills to be able to appreciate a particular problem and to be able to hold that information in mind, but they do struggle to take other people's perspectives in that social context. And one of the things that we see in adolescence is that despite being kind of the healthiest period in a person's life for most individuals, they have a much higher rate of morbidity and mortality. So morbidity and mortality rates increase upwards 200% during this period. Right? And we see that when we look at percentage of drivers involved in fatal crashes, this is quite a while ago, but those statistics are pretty similar. But that young drivers are far more likely to be involved in serious car accidents than older drivers. And that's in part because they're known for their risk-taking behavior. Adolescents will just do things that adults won't. As you can see in all of these pictures, do all sorts of silly things that put themselves in danger. The rates of substance abuse, rates of accidents, rates of suicide, homicide, eating disorders, unwanted pregnancies, sexually transmitted diseases, all of those increase in adolescence, and they all seem to be related to difficulties with emotional regulation as well as impulse control. A little bit about the neuroanatomy of adolescent risk-taking. There's two systems involved. One is the limbic system. In the limbic system, this is the reward system of the brain, and it's very, very sensitive to the reward feelings of risk-taking. It seems to be a very different reward than other rewards. Right? And the prefrontal cortex is what helps us make decisions. It inhibits risk-taking, and that's the part that's still developing for adolescents. And so this mismatch between kind of the maturation of the inhibitory control system over the affective or emotional system is what leads to these higher rates of risk-taking, as well as psychopathology like depression in adolescents. So they're quite sensitive to that feeling of reward of risk-taking, but can't quite inhibit and use their judgment. One of the things to really keep in mind, too, is that risk-taking in adolescence appears to be moderated by another variable. And that variable is social context and peers. The impact of social influence on risk perception is really strong. So adolescents are much more likely to engage in risk-taking behavior when they're around their peers than when they're alone or around adults. And it's not because they don't understand the potential risk. As you recall, by 15, 16 years of age, they're quite capable of understanding risks in a similar way as adults. But one of the things that does happen is that they spend less time with family, they spend more times with peers, and there is a fear of peer rejection and a need to conform and need to be accepted. The Blakemore Lab did some interesting work where they asked participants to rate the risk of various activities. So, for example, crossing the street on a red light, driving without a seatbelt. And participants were generally able to, identify appropriate risk for all of these. And then they were provided with ratings from other groups, either adult groups or peer groups, and asked to rate the risk again. And what they found is that peer group risk perception is very much influenced by the ratings of others. And so this effect was further impacted by the age of the kids who were doing the ratings, and then also whether the group was a peer group or an adult group. So most people, like young kids, mid-adolescents, young adults, and adults, they changed their ratings in the direction of the adult social group. But the young adolescents, the effect was reversed, and they changed their ratings in the direction of their peer group rather than the adult group. So adolescents are far more susceptible to the influence of their social groups. Some studies have found that between the ages of 12 and 17, there's an increase in wanting to conform and be accepted by their peer group. And when we think about certain behaviors that involve risk, like driving, when we look at virtual driving tasks, adolescents are actually quite good at following, at being safe and following the same rules as adults when they're alone or driving with an adult. This is why when they first get their driver's license, there is a curfew or they can't drive with peers. They have to drive with an adult. The likelihood of them engaging in risky driving increases greatly when they think they're being observed by peers. And this definitely is also seen in their brains, in terms of brain activity, right? Their neural responses during these activities when they believe they're being observed by peers is exaggerated. And the interesting thing here is that they don't have to actually be observed by peers. They just have to think that other peers are watching. I don't know where they came up with this metric, but they have said like one peer in a car approximates one drink. I don't know if it's really a one-to-one correspondence, but the whole point is that if they're driving with peers, they're far more likely to drive in a risky way. When we talk about adolescents and teenagers, we can't talk about adolescents without talking about social media. I'll definitely talk a little bit about social media use and some of the changes that we've observed over the past decade. So when I first was looking at social media use in teenagers in 2014, texting and calling were the primary ways of communicating with friends, followed by social networking sites. But texting was the big thing. And in 2014, 2015, Facebook was the major kind of social site that kids were using, followed by Instagram and Snapchat. YouTube wasn't even on the list. And now, as of a couple of years ago, YouTube is now the primary social media site that teens are using. And Facebook use has dropped off pretty significantly. So it's now YouTube, followed by TikTok, Instagram, Snapchat. There's definitely some shifts in the platforms that are being used. And you can see that here as well, right? So whereas 95% of teens now say they use, and 19% say they use it almost constantly, right? So that's a pretty large number. Whereas Facebook seems to be a pretty low yield kind of platform. Nearly half of teens now say that they use the internet almost constantly, right? 2014, 2015, about a quarter said that they used it almost constantly. And now 2022, 46% say they use it almost constantly. And over 50% of teens say that it would be hard to give up social media. So obviously, this is a very big part of their lives. And there's definitely some concern about social media use interfering with other aspects of their lives. When we think about social media use, I think there's a lot of concern about some of the cons and some of the negative impact that it may have. I think we're still learning a lot about the the pros and cons of social media use, but there are some pros. And I think those are important. And I'll definitely talk a little bit more about how the pros are also particularly evident in kids with CHD. But one of the things that social media allows for is to stay connected to friends, right? And this is a time where connection and need for belonging is really high. Meeting new friends with shared interests, finding community and support for specific activities or for specific areas of need, sharing their artwork, their music, exploring and expressing themselves. These are all really strong pros of social media use. Obviously, there's cons. When they're on social media, they can be exposed to a wide range of inappropriate content, exposure to dangerous people. There is a concern about cyberbullying, which is a risk factor for depression and suicide, oversharing of personal information, or being exposed to a wide range of advertisements. There's privacy concerns, identity theft concerns, and then also the fact that if they're using it too much, it interferes with sleep, with school, family activities. All of those need to be considered. The impact of social media on teen mental health, there's definitely been some studies that have said it seems to have a pretty negative impact. But I will say that when we look at the findings as a whole, the findings are inconsistent. We're not at a point where we can say one way or the other that it has no impact or it has negative impact or it has positive impact. It seems to be kind of all over the place. Some studies have found relationships between increased use of social media and increased mental health concerns, but others have not. And the studies that have found those relationships, the effect size or how significant those relationships were was very small. And there's also no causative findings at this point. So we can't say that, social media use is causing some of these negative mental health concerns. It's also very possible that individuals who struggle with mental health are more likely to engage in social media use as well. The jury's still out on the impact of that. So the rest of the talk is going to focus a bit more on CHD-related issues in adolescence. So one of the things that is important to remember is that if there are any neurodevelopmental concerns that show up in early childhood or learning difficulties, some of those learning struggles might become more pronounced as kids get older. And some of the executive functioning related issues may become more evident as kids reach that adolescence age. So problems with organizational skills, study skills, being able to plan, being able to keep track of what you need to do, managing a chronic illness with executive functioning issues can be quite challenging. And there's also psychosocial differences as well. So adolescence is a time where many mental health concerns kind of show up. This seems to be much more pronounced for teens with congenital heart disease. They have much higher rates of mental health diagnoses. So whereas adolescents without heart disease have about a quarter of them, a fifth to a quarter of them have mental health diagnoses, upwards of 60% of kids with CHD have mental health diagnoses in adolescence. The neurodevelopmental outcomes, some of the other workshops have focused more specifically on neurodevelopmental struggles. But what we see in childhood in kids with CHD tends to persist into adolescence. So if a kiddo with CHD struggles with learning or aspects of cognitive development, those difficulties tend to persist into adolescence. And as a group, even though they perform slightly lower in intellectual function, they're generally overall, as a group, tend to have average intellectual skills. However, there are higher rates of intellectual difficulties and intellectual disability in kids with CHD. So those, again, once they're identified, tend to persist. And those kids are going to need more support as they transition into adolescence and into adulthood. And attention and executive functioning difficulties are super common. And some of those executive functioning difficulties, again, may not become evident until kids are older, right? So they're much more likely to show up in adolescence because there's more demands being placed on those skills. But those skills, executive functioning abilities, are very much related to academic achievement, as well as their ability to manage their day-to-day life, as well as a chronic illness. So what about psychosocial development in teens with CHD? We know that they have higher rates of mood and anxiety. struggles, and that peer difficulties are also more common. Health-related quality of life. Kids and teens with CHD, both biventricular and single ventricle, overall have lower health-related quality of life than kids without any medical concerns, but this seems to be pretty consistent with other chronic illness groups. We know that because of this, we need to target some of those psychosocial domains and the peer concerns kind of throughout childhood and adolescence. I want to talk a little bit about resilience because this is, I think, an important concept, and there were some really interesting findings that I think a lot of us weren't expecting. It's not a super commonly talked about construct, although it's a really important one. But the definition of resilience is the capacity to kind of recover quickly from difficulties or withstand difficulties, bounce back, and thrive in the face of adversity. And this can relate both to emotional resilience as well as cognitive resilience and cognitive reserve. There was a study during the COVID pandemic that found that teens with CHD actually showed greater resilience than kids without CHD or who were heart healthy. And I think this finding was a little bit unexpected. But one of the things that they did find is that those individuals with CHD who had lower resilience also tended to have more hospital admissions, were less likely to exercise regularly, and were more likely to have a mental health diagnosis, and were less likely to have support from or participate in support groups or disease-specific camps. Overall, teens with CHD seem to experience less negative impact from the pandemic. And when we started to kind of try to think as to why that might be, one of the thoughts is that their prior experiences may have fostered some of that resilience, right? So these are kids who have had far more exposure to stressful events, hospital stays, surgeries, interventions throughout their childhood, which may have improved their resilience to something like a pandemic, right? So there's this concept of post-traumatic growth, of the idea that you can demonstrate positive psychological change as a result of a traumatic event. And so in CHD, that health-related trauma may potentially contribute to some of the development of this resilience and positive coping strategies for some kids. One of the things that I took away from that study too is that, one, it's important to screen for mental health concerns. We know that higher rates of mental health concerns is more likely to be related to lower resilience. Promoting physical activity and promoting social connectedness and feeling of belonging through some of the CHD-specific support communities and camps. So those all seem to be related to higher resilience. So when we talk about adolescence, the next step, or like the end of adolescence, is transitioning to adulthood. So how do we support that transition to adulthood for kids with CHD? I'm going to talk a little bit about this transition period. We're going to have a separate transition talk that focuses more specifically on all the ins and outs of transition. But there's a lot of different pieces that determine whether transition to adulthood is successful or unsuccessful. And they fall into a wide range of kind of domains, right? Your environment, where you live, if you live in a remote area that is far from a cardiac center, right, that's going to be harder to navigate. Economic stability, healthcare, education, and social and community contexts are all really important when we think about successful transition. Right? We want to make sure that we're addressing all of those areas. And so some of the hurdles that we see in terms of social determinants of health, socioeconomic status, right, and ethnicity are related to gaps and lapses in care. So that's something that we really want to be mindful as well. Psychosocial stress is obviously a big one. And identity. Adolescence is about relating to others, developing an identity and self-understanding and a sense of belonging. And so having a stronger sense of identity seems to be related to better outcomes and better perceived health and psychosocial functioning. Helping adolescents make those connections and bridge those gaps, develop those support groups is really, really important. Loneliness is related to higher degree of depression and lower perceived health. And so anxiety and depression are obviously also going to be barriers to self-management and something that we need to screen for pretty regularly. Parents play a really important role in transition. Obviously, parents are the ones who have been responsible for all aspects of their child's care throughout. Parental support shows a really positive impact on quality of life and patient-reported health and lower depression and loneliness. So feeling supported by your parents is really important during that transition period. However, parental anxiety can lead to overprotection and kind of that reluctance to shift responsibility onto the adolescent. And that can lead to more anxiety in the adolescent, more mood symptoms, and more loneliness. So there's that fine balance, right, between providing support, but also shifting that responsibility so they take more ownership in their care. Transition goals really need to be tailored to the individual and neurocognitive needs of a person, right? So adolescents with higher level of neurodevelopmental needs, we need to consider kind of what is the appropriate model of autonomy. There's various options that exist, right? We could have anything from full guardianship and full decision making for, teens who really, really struggle with cognition and development versus something that's a little bit less invasive and more shared decision making or parental oversight in certain areas for kids who have some extra needs but are able to kind of make their own decisions with support. It's really important, regardless of cognitive or developmental needs, that physicians and healthcare providers show respect and respect people's autonomy, including adolescents with the developmental disabilities, and being responsive to those individual needs. The guidelines from the American Heart Association do recommend very regular evaluations throughout the preteen and teen years because we can, that is a period where we can identify some areas of developmental need that need to be supported. Really difficult to access assessments at such a regular interval, but I would say definitely that transition, late adolescence of 14 and up, should get an assessment to kind of get a better sense of what needs for support they'll have after they turn 18. So as I mentioned, some of the commonly identified areas of cognitive struggle that are noted in childhood tend to persist into adolescence. I've already talked a little bit about some of the areas that they tend to have more difficulty in. For kids who do have intellectual disability, they're obviously going to need more adult support throughout adolescence and young adulthood. One of the things that we see a lot of is visual perceptual difficulties in kids with CHD, and that might relate to driving, spatial navigation, kind of navigating a community. So they may need more specific support in some of those areas. I already mentioned the executive functioning piece. Kids with CHD have higher rates of attention and executive functioning difficulties, and adolescence is that period where the impact of these difficulties might become more evident. When we think about that transition to adult care, it's really important to think about how some of those executive functioning struggles might affect chronic illness management. So kids with CHD often have to manage a multitude of practitioners, physicians, appointments, and medications. And since executive functioning is one of the skills that allows us to track and plan and coordinate all those aspects of care, executive difficulties can lead to missing appointments, missing medication doses, struggling to keep track of what needs to be done for their own care, and then that can obviously have significant impact on health outcomes as well. So this is where I think we need to really think through the specific needs of each individual and what support they're going to need with regard to their own illness management, right? So understanding kind of their medical care, consenting to procedures, do they need support in medical decision-making, thinking about whether certain individuals might need guardianship for medical decision-making, right? And a lot of teens might need some extra support and time before becoming fully independent, right? There's this idea that, once you're 18, you just kind of take over everything that's been done for you. And that's not realistic for most teens, and definitely may not be realistic for teens with CHD. So exploring different tools, different technologies is going to be important. There's lots of options and lots of technological tools that can be really helpful. Something as simple as like a phone-based calendar or a reminder alarms can help certain individuals with remembering their medications. There's some pill boxes that have been developed for individuals with dementia but work really well for anyone who forgets to take their medication, right? And they basically will alarm until you open the box and take the medication out. So things like that can be helpful for some teens. So one of the areas that I think is really important to talk about and really gets the needed attention is sexual health. It's an uncomfortable topic for many parents and many medical teams. For most adolescents, sexual interest is increasing, and for adolescents with CHD, there's definitely implications that need to be discussed with regard to sexual well-being. Most adolescents with CHD don't get counseling on the impact of their heart disease on sexual and reproductive health. And the appropriate counseling is going to depend on a couple of different things, including the severity of CHD, any comorbid genetic disorders, medications that are being used, the developmental kind of level of the individual. But the common areas that come up for adolescents with CHD include growth, puberty, pubertal development, and for girls getting their period, gender expression, as well as sexual activity and function, and then for girls, pregnancy and contraception. Well, I guess the contraception is true for boys too. So one of the common things is growth concerns, and that can be affected by the underlying cardiac disease, as well as the increases in basal energy needs, and can be associated with some genetic conditions that are commonly associated with CHD. Puberty is often delayed in individuals with CHD, and that can be a pretty big concern for some adolescents. And menstruation for girls is more likely to be irregular, especially for those with complex and cyanotic heart disease or those on certain medications. In terms of sexual function, the ability to engage in sexual activity should be approached like any other physical activity and on an individual basis. Other than patients with the most significant heart disease, like heart failure, valvular disease, and uncontrolled arrhythmias, some degree of sexual activity can be achieved safely for almost all patients with heart disease. And for patients who are sexually active, that sexual function should be assessed regularly because it can be affected by any underlying changes in their heart disease and cardiac lesion, and can also be a lens into something that might be changing that needs to be addressed. The impact of medications on sexual function needs to be discussed regularly as well. One of the things that we know is that kids often, if we're not talking to them about this, they're going to get this information elsewhere. And the likelihood of them getting inaccurate information elsewhere is very, very high. So having these conversations regularly can really address a lot of the concerns. Family planning and contraception, we need to really be mindful that kids with CHD have an accurate understanding of the impact of their heart disease on fertility, as well as what options for contraceptions are safe for them in the context of CHD. Pregnancy should be planned to ensure that, cardiac condition is optimized and that any genetic counseling take place. And so the World Health Organization has guidelines for pregnancy risk and contraception risk in CHD. Having those conversations about risk-benefit is really important. And so if you want more specifics on some of those risks or the risk stratification, you can find these tables on the World Health Organization website. Given that adolescents with CHD are more likely to have developmental struggles, one of the things to think about is that individuals with developmental and intellectual disabilities should also have the opportunities for healthy relationships and sexual well-being, but they might need a different way of approaching education around sexual health, and they may need additional support, right? So there's a couple of organizations that specifically tailor some of their education for individuals with developmental disabilities. That could be really good resources. And then when we think about transition to adult care, there's a couple of areas to really focus on. So first, adolescents need to have the skills for understanding their own condition, for self-advocacy, and independent medical management. And these can take several years to develop. So we don't want to be starting some of this education and practice when they're 17 or 18, right? Because then it's a kind of too late or we're going to need to give them extra time. So starting some of these conversations and starting to implement some of these tools and plans when they're 15, right, 14, 15, is going to give them the time that they need to fully develop that self-management before they transition to adulthood. A large number of adolescents are lost to adult care follow-up, in part because there's lapses in well-coordinated care. They might not have good adult congenital heart disease programs in their area. So thinking through those pieces in advance is going to be important. And when there is lapses in care, one of the things we do see is that they tend to have higher rates of emergency department visits and higher morbidity. So it's really important that we kind of try to prevent those lapses and gaps in services. Self-efficacy and kind of your belief in your own ability to carry out self-management tasks like make appointments, take your medications, are really important to that successful transition. And one of the things that we know improves that self-advocacy and self-management is shifting the responsibility for communication to the teen. So optimizing communication between teens and their providers is really important. Obviously parents are very involved in the early years and throughout their development as being the primary communicator with the healthcare provider. And so teens often kind of develop this idea that they're not the ones that are supposed to be communicating, that they're not the ones really who are meant to ask questions, and it falls on the parent as that responsibility. Shifting that to teens tends to improve their self-efficacy. There's a couple of apps and technological tools and resources that can be really helpful for transition. Some of them are more broad transition apps, and some of them are more CHD specific. But these are a couple that you can explore. There's a specific one for teens with developmental disabilities. There's one that's more CHD specific. But these are kind of apps that help guide teens through what to expect with the adult transition and what supports they might need or what they might need to be thinking about. Thank you for joining us. If you want to learn more about neurodevelopment and mental health and congenital heart disease, please subscribe to our YouTube channel and follow us on Instagram. We are called Strong Hearts, Growing Minds. In the post section of the YouTube channel, you can also find handouts on various topics, while our Instagram account will keep you updated on new upcoming workshops.